This lecture is going to be dealing with the urinary system. There are actually 2 chapters within your ebook that go along with the urinary system. This chapter that will look at the basic anatomy and physiology of the structures that are in this system, but then also a chapter that follows behind about water balance. And much of it is a little bit repeated. Some of it's repeated, but it's never a bad thing to have redundancy, especially when you are learning about human physiology. So we'll get going here with the urinary system. We are going to take a look at the organs that compose the urinary system. This seems rather simple compared to some of the other organ systems that you all have studied. For the urinary system, most people have 2 kidneys, and you can see approximately where they are situated in this illustration of this female. So 2 kidneys, a right and a left kidney. There are hollow muscular tubes that transport urine from the kidneys to a muscular bladder, and these tubes are called ureters, a right ureter and a left ureter, again hollow muscular tubes. The urine is going to be collecting in this urinary bladder, which is a muscular sac that is able to distend and hold urine between voids. And then when voiding happens, when urinating actually happens, there is a muscle, a sphincter muscle, that relaxes and allows for the urine to be sent to the exterior. And this muscular tube, in women very short and men much longer, this muscular tube is called a urethra. So kidneys, ureters, urinary bladder, which isn't labeled on this one, but urinary bladder, and then the urethra. So these are the major organ structures, which is rather simplistic, right, as far as labeling, and you all will have an assignment for your anatomy portion of this section to know where these structures actually are. And when we look at the kidney functions, I think most people understand by this point in time that the kidneys are filtering blood plasma. So when blood plasma, which is we learned in hematology, is predominantly water, that filtering of the blood plasma is going to not only remove waste products or products that are in excess that we need to clear from the system, but also water from the blood plasma. So the kidneys are major players in controlling blood pressure, because blood pressure is directly related to blood volume. The more blood volume you have inside the vessels, the higher amount of pressure in the vessels. So if you can decrease the blood volume by decreasing the water in blood plasma, decreasing blood volume decreases blood pressure. So regulating blood volume and blood pressure is a major function of our urinary system. And at the same time, it's going to be eliminating waste and keeping the good substances back into the bloodstream. So as you can imagine, and as we learned, that blood plasma has predominantly water, but it also has all kinds of other solutes like nutrients and hormones and proteins from the liver like albumin and other things. This is going to have a particular osmolarity. The osmolarity is the percentage of solutes per volume of liquid. So osmolarity of the blood has to be maintained with the osmolarity of our tissue, the fluid that's bathing our tissues, and even the osmolarity of the internal cellular fluids. So it has to be all balanced, because that's going to play a role in how water moves between those systems. So it's very important to realize that this is also a really important function of the kidneys, as they are filtering that blood plasma, making sure that just enough water is let go, just enough of the waste products are let go, but not too much, because osmolarity has to be maintained. The kidneys also secrete a precursor hormone called renin. It's not a hormone, but it's a precursor hormone that acts with another molecule from the lungs and then another from the liver that gets us to angiotensin. Angiotensin, if we remember, this is repeat for us, is the most powerful vasoconstrictor hormone in the body, which raises blood pressure, constricting the vessels. You didn't change the blood volume with that. Constricting the vessels raises the pressure inside. It also is going to initiate aldosterone to be released from the adrenal glands that will cause sodium to be retained, and water follows sodium. So we remember these. Again, this is all part of helping the homeostasis for blood pressure and even controlling electrolyte imbalance. Aldosterone playing a role in sodium retention and potassium excretion. So that's kind of a little repeat for you, but as we promised in the endocrine system, you have to continue your study and your review of those hormones. You will see them again and again. The kidneys secrete also a hormone known as erythropoietin. Erythropoietin was that hormone that targeted the red bone marrow stem cells to become red blood cells. Erythro means red, doesn't it? Means red. So erythropoietin is that hormone that will cause those stem cells to mature into erythrocytes. We said that it's not on here, but the kidneys also secrete calcitriol. Calcitriol is a hormone that will play a role in raising blood calcium levels. So that again is an important function of the kidneys. One of in the endocrine system that we talked about, sometimes the earliest indicator that there is kidney disease happening is that someone is anemic. And if they're anemic, it means they don't have enough red blood cells or hemoglobin inside those red blood cells, and it could be because they don't have enough erythropoietin. The kidneys is a major supplier of erythropoietin. Also, if you think about waste products and also excess electrolytes, this plays a huge role in acid base. The kidneys, how much they're filtering, plays a huge role in our pH balance. We just saw where in our respiratory system that you're breathing in and out at the rate that you are breathing to control that hydrogen ion concentration, which essentially means you're controlling pH. The kidneys play a huge role in this as well. So here we have two organ systems, the respiratory system in controlling your rate of respirations, controlling pH, and now the urinary system, also a major player in controlling pH. That's how important it is that pH homeostasis be maintained. A way to get rid of some free radicals in drugs is through the kidneys. Some things are actually concentrated as much as 800 times in the kidneys as blood is being filtered through those kidneys. So this is why it's so very important that people, when they are prescribed medications, that they take them exactly as prescribed, because you may reach a certain blood level concentration, but then that is so concentrated so much more in the kidneys as the kidneys are clearing those drugs, and it can damage the kidneys if you take more than what is prescribed. The kidneys are filtered for drugs, also the liver as well. So you just want to be very careful with explaining to patients that the proper treatments and how to take medications as they should. And we see people too frequently who are doing permanent damage and sometimes life-threatening damage to their kidneys and their liver when they have taken what is over the prescribed dosage. That can happen from even over-the-counter meds that don't need a prescription, and certainly it can also happen from illicit drugs as well. The kidneys also play a role in glucose homeostasis. So, we know already about the pancreas and its important role in secreting insulin and glucagon and maintaining glucose homeostasis. But now we've seen other things as well. So the adrenal glands and how cortisol and glucocorticoids can play a role in raising blood glucose levels. Well, the kidneys can also play a role in that as well. Yes, we tend to think of it as being the pancreas's job to keep glucose in homeostasis, but other factors come into play as well. So these are, if you didn't know these functions, make sure that you really concentrate on these and make sure that you understand these functions of the kidneys. The kidneys are going to be eliminating waste. So some of those waste products, when we think about what is the waste products that are created in our system, urea is a major component. I've talked to you about your cells being essentially protein factories. Your cells can produce carbs and lipids and nucleic acids also, but they're essentially protein factories. And it's the proteins that are the most diverse in the organic molecular categories. So when we think about proteins, we know that their monomer units are amino acids, and there are 20 different amino acids that can come together to form these long chains that make up our proteins. Their structure dictates their functions. But proteins break down. They're not formed and then last forever. They denature, they're broken down for natural causes, and then you remake them. Oftentimes you just reuse those amino acids, recycle them, and build new proteins that are needed in the cell. But there are sometimes some waste products when this nitrogen group is actually removed. It takes enzymes from the liver to convert some of these byproducts. So immediately ammonia is going to be formed, but the liver produces enzymes that convert that to urea, and urea can just be excreted. So thank you, kidneys, and thank you, liver, because we need them all to be able to excrete these normal, natural waste products. The proteins breaking down causes urea. We can get rid of it. Nucleic acids breaking down, when nucleic acids break down, there's a byproduct called uric acid. Uric acid can also be excreted by the filters in the kidneys. When people have trouble getting rid of uric acid and uric acid builds up in the bloodstream, it can actually migrate to joints, synovial joints, and an excess of that uric acid can cause what we call gout. So gout is going to be a very painful joint situation where uric acid has formed crystals in those joints. So that's what gout actually is. But uric acid is a natural waste product of nucleic acids breaking down. And you remember, our cells all have nucleic acids. They have RNA, several types of RNA and DNA, and a lot of those monomers get recycled, but not all of them, and uric acid can actually form. Creatinine is going to be a byproduct from the creatine phosphate breaking down, which is a normal product in our muscles and our cells, but as it breaks down, creatinine can actually form, and that's also easily taken care of by functioning kidneys when they are functioning. Now, what happens if you can't get rid of these three products? If the kidneys stop being able to filter the way that they should and get rid of these, is something called, what we'll see first is called azotemia. Azotemia is actually when the blood urea nitrogen, that's what BUN stands for, and you should know that, blood urea nitrogen and nitrogenous waste increase in the bloodstream. That's called azotemia. Azo as a prefix is referring to proteins. So azotemia is when you will see an increased BUN on the chemistry results from pathology, and that indicates that these nitrogenous byproducts are building up in the bloodstream. And if it continues to go on for too long, then you will start to see toxic effects. As those toxic effects are becoming visible to you, the patient is said to be in uremia or having a uremic syndrome. So uremia. These are when now you're seeing the damaging effects of this increased BUN of azotemia. You're now seeing the bad effects of that because the tissues are starting to suffer. So these are nitrogenous waste products, and then we also have other excretory, well, it didn't really say, okay, sorry for that interruption, but we'll continue on. So the urinary system isn't the only excretory system. There's also the respiratory system. We're breathing out CO2 and getting and in the process getting rid of the hydrogen ions. The integumentary system, we can excrete a lot of waste through our skin. The digestive system, and obviously the urinary system. There are other wastes that are gotten rid of than just nitrogenous waste, non-nitrogenous waste products, like we were saying with drugs and excess electrolytes. All of those would fall under the non-nitrogenous waste. But the major thing that we think about that we must be able to get to clear with functioning kidneys are these nitrogenous waste products. So when we think about the anatomy of the kidney, they give you all kinds of descriptions here, but when we think about this anatomy of the kidney, this is a great illustration of a coronal section. So they have taken a dissection, removing the front from the back so that you can see inside of the kidney here. I would like you to pay attention to a couple of things here before I continue to talk about microscopic histology slice of the kidney. So this is the cortex, the outer layer, and you will notice that there are these pyramid like structures that you see here leading to these hollow tubes. These tubes are called minor calyxes, and then minor calyxes join to major calyxes, and then eventually to the pelvis. This is referred to as the renal pelvis, where urine is going to be exiting through this ureter, this hollow tube that is called a ureter. But when we look at the kidney itself, this coronal section, even on gross anatomy, just looking at it with your eyes, you can make out a very smooth outer cortex and then these pyramid-like structures. What we're going to do to figure out how the kidney actually filters is to imagine taking a slice, a knife, and slicing into this cortex and going down into the pyramid structures, a 2 to 3 layer cell layer slice, and looking at that under a microscope. If we did that, we would see these repeating little structures. And if you look at this structure here, it looks like there's a little red ball there, and then there's these little twisted tubules, and here's another repeated structure, and here's one, and here's one too. These structures are called nephrons. The functioning units of a kidney are nephrons. They are microscopic. They are microscopic little filters. And in each kidney, you have millions of these structures repeating. They are where the filtration is occurring. The initial filtration is occurring in the nephrons. So when we think about our blood plasma, we saw in hematology that if you spun whole blood down, the cells would be packed, and then most of blood is that extracellular fluid that we call plasma. These nephrons are where that plasma gets filtered. And I'm going to explain to you what is happening in a nephron, using one nephron as an example to tell you what is actually happening at that level. Okay, so this is not a very great, I think they could have come up with a better picture of a dissection from a cadaver of a kidney. What I want you to see here, and I'll change this so that it'll be close. Really? Well, it won't be that close. All right, maybe I won't. Maybe I won't be able to change it. All right, so what I want you to see is if we took this slice and we looked at this, we see each of these nephrons, there is this round little, it looks colored here as a little ball almost. That structure is called a glomerulus. This is the glomerular capsule encompassing this, but this whole structure here is known as the glomerulus. This is where the first filtrate happens. So the glomerulus is the first part of the nephron where the filtrate happens. You would want to know. Blood comes in through this afferent arteriole. Blood comes in, and it moves into this glomerulus, and you will see there it goes through this lots of surface area in the glomerulus where it is actually going through a filter. Now what can't go through the filter, because there's pressure behind this, blood is moving due to pressure, so the blood comes in, and what gets filtered out is actually the blood plasma. Everything in the blood plasma except for proteins. So cells can't get through here, and plasma proteins can't get through here. They're going to end up going out through this efferent arteriole. So the blood that's coming out here is really sludge-like, because the plasma, the water, all of the good stuff, everything except for proteins in the plasma has just been filtered out. And it is now in what is called this PCT, or proximal convoluted tubule. But think about this. So as blood is pushed through, whole blood comes through at a microscopic amount, the pressure is enough that it's pushing everything out of the blood plasma except for proteins. Proteins are too big to get through these pores, and cells can't get through these pores. So this is being forced out in this little blood vessel, and it is sludge-like. But in this proximal convoluted tubule, this hollow tube, is now the good stuff in the plasma as well as waste products, and we've got to get a lot of that back, and we've got to get a lot of it back to this blood vessel as soon as possible. So now when you look at this glomerulus and you know that that's happening, you see that there is actually all of these blood capillaries here, and immediately from this proximal, if you see this proximal, convoluted just means twisted, right? Tubule. Proximal means near the glomerulus. Proximal, near. Convoluted, twisted. Immediately diffusion and osmosis is occurring. So immediately water, and through diffusion of solutes, the good stuff is coming back to the bloodstream. Thank goodness, because it was sludge-like right here. So it's immediately starting to be pulled back. When we think about how much urine an adult makes per day, it is approximately 1.5 to 2 liters a day, depending on how well hydrated a person is. But that's a normal amount for an adult, 1.5 to 2 liters of urine output a day. But listen to this. The kidneys and these little filters that are filtering minute amounts of blood at any given time, but it's millions of them happening at any given time. The kidneys filter about 150 liters of blood a day. 150 liters a day. That means that 99% gets reabsorbed. So of that plasma filtrate that happened right here in the proximal near twisted tubule, proximal convoluted, much is being reclaimed. Much of the water, much of the good stuff. Hopefully, the only thing staying in this tubule is going to be the excess water and the waste products, the things that you want to clear and get rid of. But this is twisted so that you have plenty of time for reclaiming. It even goes through this loop. This is called the loop of Henle. I think they call it a nephron loop, but it's the loop of Henle. This nephron loop, and this is, again, they don't show you this, but there's all kinds of blood vessels right here, just like you can see them here. So reclaiming through diffusion and osmosis, through a 1-cell layer thick tubule and 1-cell layer thick capillaries. So quickly that reclaiming is happening here. And it goes through the loop, and then it goes through this distal convoluted tubule. Still reclaiming happening until this nephron connects with the collecting duct. This is called the collecting duct. This nephron, this distal convoluted tubule is connecting. Here's one that's been cut for you. It's been cut. There was a nephron here. There was a nephron here, a nephron here, a nephron here. And the entire time, from the very first glomerulus filtrate that happened in this proximal tubule. It's so twisted and it has such a ways to go through the proximal, the loop of Henle, the distal, the collecting ducts. It's being reclaimed, the good stuff, with only the excess water and the waste products supposedly remaining in this tubule. This is not called urine. It is not urine yet. While the reclaiming is happening, it's just filtrate. It's the kidneys have filtered the blood plasma, and it's called filtrate. But much reclaiming is actually happening. It's being reclaimed from the proximal to the loop, to the distal, to the collecting ducts, and even from all the way here until it can't, the structures are too large and too thick for reclaiming to happen, and now you're in those papillary duct, the minor calyx, major calyx, which we saw, the pelvis, the ureter, the bladder, and the urethra until it's out. So it's really not called, that filtrate is not called urine until no reclaiming is happening again anymore. And remember, from the very first filtrate, 99% of it will get reclaimed. And what becomes urine is only about 1% of what the kidney's filtering, and that is happening at these ducts, these larger ducts. So that's an important concept for you to know. So the flow of, and as they're calling it, filtrate, the flow of the filtrate happens this way. The first is happening in the glomerulus. That filtrate moves into the proximal convoluted tubule, through the loop, this loop, to the distal convoluted tubule. You can follow my mouse. This is a distal one, until eventually the collecting duct, which is this, many nephrons attached to the collecting ducts, water being reclaimed the whole time, and finally becomes urine because no more reclaiming is happening, and enters into the minor calyx, the major calyx, the pelvis, the ureter, bladder, and eventually is excreted through voiding from the urethra. So I hope that that makes sense to you, and this is exactly how the kidneys are filtering. So we have millions of nephrons where the filtration's occurring, but we only have a finite number. We don't have an infinite number of them. So if nephrons start to get damaged or destroyed, maybe you can sense, since they're so one cell layer thick, you don't get them back. So if you lose enough of them, you're starting to lose kidney function, and you don't get them back. The amazing thing is that people can typically filter enough of their blood to remain in a state of balance and health, even if they have as low as 15 to 20% of their kidneys functioning. That's pretty amazing what your kidneys are doing, these nephrons. I'm not suggesting that you want to lose that many nephrons or that much of your kidney function, but your kidneys can try to compensate if there's been damage, and blood can actually be filtered through those remaining glomeruli, those remaining nephrons. So, you know, that is an important thing to think about too. And you've heard of people who are born with just one kidney and they're fine and they can function with one kidney, and they really can. So, but then you also hear about people donating, like living donors can donate a healthy kidney to someone who needs one, and then still they can be okay because it can filter. Remember, a normal size adult has anywhere from 4 to 6 liters of blood circulating, but that much blood goes through the kidneys 150 liters a day. So blood is really being filtered through those kidneys at quite a fast pace. So this is also, if you think about that, this is also why if you have an injured kidney, you can bleed out because of the blood supply that's coming to the kidneys for the blood to be filtered, and it can be a life-threatening thing if the kidneys are lacerated or bleeding out. So I hope that looking at that helps you to understand how the kidneys act as filters and what exactly is going on. Again, the blood flow is causing that first filtrate to happen, and much of that is actually being reclaimed. When you look at the pores that are in that glomerular filtration, that glomerular capsule, those little structures that are acting as pores, this is how the filtration can happen so quickly. And the blood pressure plays a huge role in how that is happening. If blood pressure is too high coming in, there are cells that are sensing this, and they can clamp down on this afferent arteriole to slow the filtration rate down. You don't want this coming in too fast or the pressure to be too high, because the kidneys cannot withstand that kind of pressure, and it ends up destroying this glomerulus. And as I said, over long periods of time, enough of those nephrons being destroyed, and you don't get them back. One of the most common causes of kidney failure and people losing the function of their kidneys and needing to go on dialysis is actually due to hypertension, high blood pressure. The kidneys can withstand the systolic level, which you all know is the upper level, the highest amount of pressure being exerted on the arterial walls. They can withstand a fairly significant systolic, but not for long periods of time. So, our systolic level goes up in times of stress and times of activity, and that's all normal, and the kidneys can handle it. But if somebody is chronically hypertensive, or if that systolic is at a dangerous level, that's destroying the kidneys. That's destroying the nephrons, the glomeruli, and the nephrons. And over time, enough of them being destroyed will reduce kidney function. And so, when they are testing for kidney function, they're looking at the BUN, the blood urea nitrogen. If it's starting to go up, or they look at other parameters as well, then they can get an indication of whether the kidneys are not functioning the way that they should. This glomerular filtration rate is a test that a urologist is a specialist in this particular system. He or she can test the glomerular filtration rate. They often will be able to evaluate how much filtrate is happening per minute. And as I said, if you think about just for a female, a normal 150 liters a day, with a normal output being about 1.5 to 2 liters of urine excreted, that means 99% needs to be being reabsorbed. So they can measure this. What's going to happen if there are abnormalities? If the glomerular filtration rate increases, then that means the urine output is going to increase, because no matter how much you can reclaim, if your rate increased, you're probably going to have an increased output, which can lead to dehydration, and it can lead to electrolyte imbalances. So electrolyte imbalances can be dangerous. We'll talk more about that in the next chapter, but we already understand about how important potassium and many of those electrolytes are, sodium and potassium, to control action potentials for our cells. A decreased glomerular filtration rate means that now wastes are building up. Azotemia will be the first sign that this is happening, with an increased blood urea nitrogen, and if left unchecked, if the kidneys continue to not function the way that they should, you're going to see the toxic effects to the tissues, which is called uremia. Now, what controls the rate? Thank goodness we don't have to think about it, do we? It's the autonomic nervous system. So again, looking at this glomerulus, and here's the proximal convoluted tubule. This afferent arteriole is bringing blood in, but there are these cells that are measuring the stretch on that and how fast it's happening. And if it's too much, they will get a signal to clamp down and slow it down. It's just a classic negative feedback system that is controlling this. And it's auto-regulated, and it typically does a very good job of auto-regulating so that the the nephrons don't get damaged. It's pretty stable for, like I said, a relatively, for short periods of time, high systolic level. It just cannot compensate for long or extreme high systolic levels. It's just too much for that. So again, just kind of a classic negative feedback. You could look through and see that. We do know that, exercise and those types of things can influence this. So we have this autonomic nervous system is going to control our hormone output. So when you think about the hormones that are going to have a huge role in this, angiotensin, which took a precursor from the kidneys, precursor from the liver, precursor from the lungs, to cause angiotensin to be made. This causes vasoconstriction. That is going to raise blood pressure, but it's also going to cause you to be thirsty, which usually if you're thirsty, you go get something to drink. That's going to increase your fluid intake. But it's also signaling the adrenal glands to secrete aldosterone, which causes the reclaiming of sodium, targets the kidneys for reclaiming of sodium. Where sodium goes, water follows, and that all elevates blood pressure. So that's just kind of a classic negative feedback where there was a drop in, because our blood pressure goes up and down all day. So when it drops like this is the classic feedback that actually happens. So these slides are all pertaining to this. I like this visual because it shows you some of the great stuff that's in that first filtrate. This is not urine yet. These are in the tube. So the PCT, the loop of Henle or Nephron Loop, the distal convoluted tubule. So you think about all the water that's in there that you've got to reclaim, and then all this good stuff. You don't want to reclaim the urea, uric acid, but you want to reclaim, there should never be glucose in urine because you've reclaimed it, right? You've reclaimed your electrolytes. You're reclaiming what you need, and it's moving through that one cell layer thick tubule into the capillaries, the blood capillaries, and your 99% is being reabsorbed. Now, I want you to pay attention to glucose here because glucose is going to be in that first filtrate, but it should never be a normal finding in urine. So it should have all gotten reclaimed, all going through those little twisted tubules. It needs to be reclaimed along with a lot of other stuff, especially water. But anyway, to reclaim glucose, these tubules have specialized receptors for that. So the glucose has to encounter those receptors. It's one of the reasons it's going through these twisted tubules. The glucose molecule encounters the receptor, it pulls it through and takes it back to the bloodstream. There is something called renal diabetes. I want you to write that down. Renal diabetes are when you are born with, so it's inherited. It's an inherited lack of these receptors. And when I say an inherited lack, it's not a complete lack. It's just they are not functioning the way that they should, or there's not as many of them. So what ends up happening, people with renal diabetes, the glucose is staying in this filtrate, which is changing the osmolarity of this filtrate, and then water stays. And because water is staying more than it should, not all water, but more than it should, you have an increased urine output because it changed the osmolarity of this fluid, this tubular fluids, because glucose is not getting absorbed the way it should. An osmolarity changed, so fluid reclaiming changed. So diabetes, we said, is an excess of urine output. But this is going to cause glucose to be in the urine. Glycosuria is a word that means glucose in the urine, glycosuria. But it's happening and you don't even have too much glucose in the bloodstream. Now, glycosuria can also happen if you have diabetes mellitus. Diabetes mellitus means that there's a lot of glucose. There's a whole bunch of glucose in the bloodstream, too much, hyperglycemia. It's so much glucose in the bloodstream that it wouldn't matter how long these little tubules were. There wouldn't be enough time to reclaim it all because it's too high in the bloodstream. So then you start to see glucose in the urine, and so that's diabetes mellitus. But renal diabetes is very different. There wasn't too much glucose in the bloodstream, and now you're losing it. So a problem with renal diabetes is that you can actually be hypoglycemic because of that, have too little glucose because of your renal diabetes. I hope that is making sense. If it's not, then you might want to re-listen to it because you would want to understand that. There are more types of diabetes than just diabetes mellitus. We learned about there are several types of diabetes mellitus. There's type 1, type 2, gestational diabetes mellitus that you see with people who are pregnant, which is a high risk pregnancy for mother and fetus. And then we saw diabetes insipidus that had nothing to do with glucose, only had to do with ADH. And now there's renal diabetes that we're talking about because of a lack of these receptors in the kidneys that help to transport glucose back from the filtrate into the bloodstream and not let it get lost to the urine. Okay, so waste removal, and we see all these waste products, including the nitrogenous ones, but not just including those. Acid-base balances, letting hydrogen ions go if we need to. If we need to bring that pH back up, we can just let those hydrogen ions go. Or if we need to keep them in, we can keep them in. So this is what is happening in those little microscopic filtration units called nephrons in your kidneys. You have ADH, which you all have learned about. Please review it because you'll be asked questions again from this chapter. You have the ANF. You know ADH raises blood pressure by causing you to reabsorb the water, decreasing urine volume. If you don't know that, then, I mean, we should know that at this point, but go back and look. ANF is really the opposite of what aldosterone does. I call it ANF or ANP, peptide or factor. This is from the heart that's going to secrete this hormone to cause sodium excretion. So it's the opposite of aldosterone, and water follows, so you have an increased urine output, which lowers your blood volume, which lowers your blood pressure. Right. We have PTH, which is parathyroid hormone that is going to be secreted from the parathyroid glands. This targets the kidneys so that you pull calcium back in. So in essence, what I'm saying is this nephron unit that is, emptying its filtrate into the collecting duct. There's many nephrons attached to a collecting duct. These nephron units and these collecting ducts are influenced by hormones and what you're going to reclaim and what you're not going to reclaim. Hormones. When we learned in the endocrine system that a hormone targeted the kidneys, now you see where it targets the kidneys. It's targeting at these filtration units, these structures that actually will play a role in what gets reclaimed and what won't get reclaimed. So we're seeing a little bit more than just saying that it targets the kidneys, right? So anyway, great. Now, this is a chart just reminding us of all of those hormones. Please review it. Please review it. I won't ask you specifically which areas it's targeting in the kidneys, but just to let you see that this is how this is promoting what it does. Now, the next part or really kind of the last part of this chapter is actually dealing with urinalysis, and that will be the next thing I speak about. I'm going to take a quick break. I'm going to be right back. Okay, so now I want to talk to you about what is considered to be by diagnosticians, people who are trying to figure out what is going on with their patients, is the most important test that they can order. One test. If they only had one test that they could order, what would be one of the most important tests that they ordered that could give them an idea of the overall well-being of their patient? It would be a urinalysis. So, we've talked about CBCs, complete blood counts. There are chemistry panels that can be done on blood plasma and blood serum, the serum part of plasma. So there are all kinds of tests that do get ordered on a routine basis. But where we know diagnosis comes from now is actually the pathology department in the labs. And sometimes people are actually depending too much on that, so they order everything. It's sort of like just ordering everything when a patient comes in with A, B, C symptoms, and maybe they only needed one test. People are getting all kinds of tests being ordered on them, and it can be kind of a problem. So it can add to everyone's medical cost and, the expense of what's going on in the hospitals and labs and clinics. But anyway, if you only got to do one test, a urinalysis would be a good one to do to give you an overall idea of how a patient is actually doing. So how you collect the specimens is important. Test, whether it's a blood test or, a throat swab or a wound culture or urine sample. The test will only be as good as the integrity of the specimen that was collected. So it's very important that people know, and it's usually nurses and whatnot that are helping to explain sometimes retrieving the specimens, getting the specimens, but also explaining if a person needs to give a urine sample, exactly how to best go about giving that sample so that it can be tested and you can feel confident in the results. But the first thing that happens is that you just look at it. You look at it on gross anatomy, looking at it with your eyes, and you assess the appearance. Urine should be clear, colorless, and copious, meaning that you should be making plenty of urine in a day, and it really shouldn't be cloudy, and it should essentially be colorless, almost colorless, but sometimes it can get to deep amber. And the reason it becomes deep in color, this yellowish amber color, is because it's so concentrated. Now, urine should not really be so concentrated. There should be plenty of it. If it's almost colorless, then it means that you're well hydrated. If it's deep in color, it means you're probably dehydrated. You're walking around dehydrated. Dehydration puts a burden on every organ system. So again, sometimes just being able to look at what urine looks like can tell you a lot about how a patient is overall. Odor, if it's allowed to stand, urine will actually degrade to ammonia, so it takes on that sort of smell. But when it's just recently voided, it shouldn't be malodorous. Sometimes they are, and it can indicate whether someone has a urinary tract infection. Most urinary tract infections are actually caused by, actually it's just a handful of bacteria that cause urinary tract infections, and most of them have a very distinctive odor that will be given off when a person has a urinary tract infection, a UTI. When somebody has a UTI, this is a good place to talk about this. The urinary tract infection isn't usually of the entire tract. It isn't of the urethra, the bladder, the ureters, and the kidneys. It's usually isolated. So if someone has a urinary tract infection, it may be urethritis, which is inflammation of the urethra, which is really painful. That's when people say it really is painful to urinate. It could be cystitis. Cystitis is inflammation of the urinary bladder. Cyst means a fluid-filled sac, and this inflammation of a fluid-filled sac, in this case, it's the urinary bladder, which is a fluid-filled sac. It's filled with urine that you're holding to void. Anyway, cystitis. It could be ureteritis. Ureteritis means inflammation in one of those ureters. Or it could be nephritis. Nephritis is inflammation in the kidneys. So obviously when someone has a UTI, you would really like to know where it is along the tract. Most common ones are urethritis and cystitis. That's the most common. If someone has nephritis or ureteritis, they typically are in the hospital on IV antibiotics. UTIs are fairly common, especially in women. Women's urethras are much smaller than men's. Men's are much longer. The urethra being so small in a female, and because of where the opening of the urethra is in a female, it's so close to the vaginal opening, then they're just more at risk of having infections. Most of females post-puberty females most urinary tract infections or urethritis or cystitis caused from a bacterium called Escherichia coli. Coli is the species. Escherichia coli is part of their normal flora, the women's normal flora. Everyone has E. coli in the perianal area, and E. coli is a bacterium that is very motile. It has a flagellum and it can move. So there's certain practices that, sort of bad practices, that women may be actually self-inoculating themselves with this bacterium that can rather quickly move up a very short urethra and cause urinary tract infections. So women are, told proper hygiene techniques, always, bathing and wiping front to back, not back to front, if you will, because that can introduce women, especially post-puberty, being very careful that they are well hydrated and they're frequently voiding and not holding urine, for too long, because when you void, you're clearing that urethra. It's washing those little bacteria away that are actually just part of the normal flora that are in that opening of the urethra. So frequent voiding, making sure that you void completely, you don't leave any urine in the bladder, proper hygiene practices and techniques, urinating after intercourse. That's very important, because intercourse can actually introduce some microbes to that area, and so you want to void, flush that after intercourse, those types of things. So men, because their urethras are much longer than women's, men's urinary tract infections are usually from different types of microorganisms. Actually, the microorganisms, the bacteria that we see, is part of normal skin flora. So obviously we also know that on occasion this urethritis can be caused from microorganisms that are sexually transmitted as well, but not usually. Usually it is part of the person's own normal microbes that are causing the problem. But anyway, so smell, odor. If you've ever worked in a skilled care facility or hospital or an emergency room, you know that as soon as a patient gives a urine sample, sometimes whether there's infection or not, because it can really tell you. You can also tell if somebody has diabetes mellitus. If it's got a lot of glucose in the urine, you can smell it. So that's important to see. Whether somebody's very concentrated or not. The specific gravity means concentration. Like I said, this can give you an idea of the patient being hydrated well enough, or if they're dehydrated. Again, osmolarity plays a role in that. pH, the pH for urine has a broad normal range. So blood and body fluids are typically a really narrow range, 735 to 745, but not for urine. Urine can be down as low as 5, pH, and as high as 8 or 9 pH, because this is the system that is controlling that hydrogen ion concentration. So that's just normal. We would really like to see urine in a very acidic situation, like 5 or 6. That's where we would like to see pH in urine. pH in urine that way would actually help to reduce the incidence of infections too, because it would discourage bacterial growth as well. But it just means the kidneys are functioning as they should, and they're getting rid of the hydrogen ions when there are excessive hydrogen ions, and it's not going to be putting such a burden on the respiratory system to do so. So this is a lot you can tell from just taking urine, looking at it, assessing it that way, even smelling, but then doing a dipstick. This is called a dipstick, that has a little strip of chemical pads that can be done right there near the bedside of a patient. So there's all kinds of parameters that you can see. You can see glucose. You can look for glucose. You can look for white blood cells. There shouldn't be blood cells. There shouldn't be white cells, red cells, or any cells in urine. If there are, then you need to figure out why. If they're white blood cells, that would indicate infection. If they're red blood cells, that can indicate sometimes infection, but it can also indicate other types of situations, even trauma. So it can indicate kidney stones, as stones are moving, renal calculi or kidney stones, as they're moving through, they can be causing some damage and that sort of thing. So a urinalysis is a great test to do, and again, can just tell you so much. When we think about normal output, I would like this to say 1.5. 1 is getting a little low. 1.5 to 2 liters a day. Poly means excessive, right? So too much urine is over 2 liters a day. Oliguria is you're beginning to have too little, so about a half a liter. This 500 mLs is a half a liter, right? A half a liter a day. And then if the kidneys aren't functioning at all, you have what is known as anuria without urine production, is what that would literally be broken down to. And the person's not producing any urine. So this is when they're starting to need to go on dialysis, where blood has to be removed from the body, filtered outside of the body, and then put back in. So we had talked about diabetes, and we know that that's a term that just means an excess urine output. So you can have chronic polyuria, and it can be with hyperglycemia, with high glucose and glucose in the urine. That would be diabetes mellitus 1 and 2, gestational diabetes. But you can have it without hyperglycemia, and I told you that's renal diabetes, and it's because you don't have those transporters. That's inherited disorder. And then you can have nothing to do with glucose because it's an ADH problem, and that's diabetes insipidus. So I talked about that. Diuretics cause you to increase your urine output. So that's what they're going to do. Now, when they increase your urine output, we know urine is just filtered blood plasma. So that means it's decreasing the blood volume. If you increase your urine output, that came from blood plasma. So that volume decreases, and that decreases blood pressure. So it is used in hypertension and in congestive heart failure situations, and it's going to end up decreasing blood pressure. So how it works is by increasing glomerular filtration. So the rate increases, the filtering from, let's say you were 150 a day, it's going to increase, and that's just going to mean that there's going to be more filtrate that ends up becoming urine. It also decreases that tubular reabsorption. So claiming of 99% is going to go down to 93, 94% claiming. So it has a couple of different mechanisms for how diuretics actually work. Renal function test can be done by looking at creatinine clearance. Sometimes this can be done by drawing blood at a particular time and then testing the urine. Sometimes they will do 24-hour urine sampling and actually see exactly how much creatinine is being cleared in a 24-hour period. And again, they can evaluate how well those kidneys are actually clearing and functioning. We talked about the ureters as being these hollow muscular tubes that transport what is now urine. It's not called filtrate anymore. It's urine from the kidneys to the bladder. They need to make sure that they're not blocked. Sometimes stents have to be put in to open up a ureter if there's a problem there, and they are draining urine from the kidneys to the bladder. There's a little opening here where these ureters start filling the bladder, and if the bladder gets too full, because it can expand, it's a muscular sac, it can expand, it usually is going to cut off, sort of press against that tube and stop this, because the bladder can actually rupture. So it's sort of a built-in mechanism so the bladder won't rupture, but usually well before that point, as long as you have normal sensations and everything's functioning the way that it should, you're going to have the sensation to urinate. And there are two round muscles, the internal and the external sphincters, that control voiding. So usually you have control of this around the age of 2 to 4, and before then you do not have control of that. But anyway, after that you typically do, and you're able to void. So this is a female urethra, is very short, right? And then you can see a male urethra. The males, an important thing to show you here is that, and for you to get, is that the urinary system for a female is completely separate from her reproductive system. Reproductive structures are completely separate from the urinary structures, where that is not the case in males. Males have shared structures. Shared structures, it doesn't show you here, but the ejaculatory duct where sperm is actually going to be introduced to the urethra is right here near the prostatic part of the urethra. This gland that you see that's been cut here is the prostate gland. So sperm enters here, and so they're shared structures of the urinary system in a man with his reproductive, and we'll get to that when we look at the reproductive system. But you can see a male's urethra. There's the penile urethra, the prostatic and the prostatic urethra here, and then the bladder. So different regions. But anyway, let's see what I was wanting to do. Okay, so I think this is all with the bladder. So the bladder can really expand to amazing proportions, really. Not that it's recommended that anybody holds that much urine at a time, but it can hold up to 800 cc's or mLs, almost a liter. Again, not recommended, because it can, it's just setting somebody up for potential urinary tract infections if they hold urine too much between voids and that sort of thing. I'm trying to think if there's anything else I wanted to tell you about with this. I mean, I don't think so. So okay. These are some of the anatomy, the last with little parts with the anatomy. The urinating, the actual term for that, medical term, is micturition. Micturition is just that means voiding urine. And again, we usually have control of that after the age of about 2 to 4. Usually by then there's control of that. If there's been nerve damage, for whatever reason, people can actually lose the ability to feel the sensation, so they lose this ability. Incontinence is a term that is used for not being able to control voiding. So there's all kinds of different reasons for that. It can be because of nerve damage. It can be because of other things as well. Sometimes it's stress incontinence, so people can have, you hear about people who leak some urine when they sneeze or cough or laugh, or I don't know, whatever reason. So that can happen as well. So there are quite a few things that can lead to incontinence, and I think pretty sure you have a deeper insight on talking about that. What I do want you to see, and this is such an ancient picture, no idea why this doesn't get replaced in your ebook, but anyway, this patient has a shunt that has been put in, and so blood is being removed, run through an external filtration system with dialysis fluid, and then put back into the patient here after it's been filtered. Someone on full-time dialysis, it typically takes 3 days a week. So they do, Monday, Wednesday, Friday, or, Tuesday, Thursday, Saturday, whatever. It's usually 3 days a week, and it's almost the whole day. So when you think about the time it takes to get to the dialysis center, getting hooked up, that's usually 4 or 5 hours it can take to go through that, you're sitting there, and then getting back home. So it's really affects life when someone is on full-time dialysis. And not just that, you can imagine that anytime anything invasive is done, it can be a life-threatening, kind of thing. So people sometimes can be on dialysis, full-time dialysis, for years and not have, other than huge lifestyle changes, never have too many complications. But other people can go on dialysis, get the shunt put in to protect their, you can imagine you wouldn't want to be accessing these vessels every time. So after a shunt's put in, they will, in the first month, throw a blood clot, and it can be life-ending. So dialysis is a serious medical intervention, and this is why people on dialysis are usually looking for kidneys, if they can at all be on a list that they qualify to be able to get a donated kidney. So the last The last slide is showing you some disorders of the urinary system. I have also included that as in a Word document, but these are some of the things that you would want to look at. Most of these we have actually talked about. Acute glomerular nephritis, inflammation of those nephrons, specifically at the glomerular level. Acute means the symptoms, signs and symptoms come on quickly and they're serious. This is because of post-streptococcal infections. When somebody has a strep throat, their throat pharyngitis, they have a sore throat, they're not getting treated for their sore throat. Their sore throat would go away. Eventually it would. And their sore throat from strep is not going to kill them. What they're getting the treatment for is to prevent this, because this can kill them. It can destroy their kidneys. I've seen children come in the clinic at UVA whose both kidneys were gone from post-streptococcal infections that weren't treated. So this is the reason this is one of the reasons that people get treated for streptococcal infection, strep throat, with antibiotics, and it works. So since the advent of antibiotics and people seeking, treatment, usually when they need to. Now, not all untreated strep throats are going to lead to this. Most people who have strep throat will resolve from it. I'm not suggesting that you do that without an antibiotic, but I'm just telling you most would. But on some occasions, that post-streptococcal infection, because of the immune system response, will shut down the kidneys. So that's what acute glomerular nephritis is. So you guys can look, I just talked about some incontinence issues, and you all can look through these. But I finished this chapter. The next chapter really goes hand in hand with this one. It's not a lot of new information. It talks about those hormones again. That's how important they are. And electrolyte balance. So we'll do that one next time.